I'm Kaylin Wilson, a student at Vanderbilt University School of Medicine, and today I will be discussing cancer cachexia. In this video, we will define cancer cachexia and understand why it's an important public health issue with ever-increasing impact on our aging population. We will also learn to identify patients with cancer cachexia based on diagnostic guidelines. We will then explore some of the complex mechanisms contributing to the development of cancer cachexia and review current and future treatment options. What is cancer cachexia? It's a complex, multifactorial condition characterized by a loss of body mass, particularly skeletal muscle mass, which distinguishes it from starvation, where fat is usually depleted first. It's a condition that cannot be fully reversed by nutritional support, and it leads to progressive functional decline in affected patients. Why is this important? Well, we know that cancer is one of the leading causes of illness and death in the United States, and these data from the National Cancer Institute show that between 2012 and 2016, the most common age of patients diagnosed with cancer was 66 years old. In fact, over 50% of cancer diagnoses and about 70% of cancer-related deaths occur in patients 65 years of age or older. Evidence also shows that cachexia is a common issue in individuals with cancer. These data come from a study published in 1980, which evaluated weight loss and clinical outcomes in over 3,000 patients with cancer. As this chart shows, weight loss of at least 5% of total body weight was common across many different types of cancer, with rates as high as 64% in gastric cancer. In fact, more than half of the patients in this study reported having lost at least some weight in the past 6 months. This study and many others have also shown that cachexia in cancer patients impacts outcomes and quality of life. As you can see here across 3 different cancer types, weight loss was associated with shorter survival, and the more severe the weight loss, the shorter the survival. Studies have shown that cancer patients who are cachectic have reduced response to and ability to tolerate therapy, particularly chemotherapy, as well as reduced survival, poorer performance status, meaning less physical strength and ability to care for themselves, and reduced quality of life. In fact, about 20% of cancer-related deaths are thought to be directly attributable to the effects of cachexia. I hope I've convinced you that cancer cachexia is a serious threat to health, especially for our older population. So, how do we diagnose it? Many criteria have been proposed, but we will focus on one set developed by an international panel of experts in 2011. These criteria state that a patient with cancer has cachexia if they have weight loss greater than 5% over a 6-month period, not due to starvation, or BMI less than 20 with weight loss of 2% or more, or sarcopenia, meaning muscle loss, with weight loss of 2% or more. There are several ways to diagnose sarcopenia, including calculation of muscle mass on bone density scan or a cross-section of the lumbar spine on CT. However, the easiest way is by measuring the circumference of the mid-upper arm, from which mid-arm muscle area can be calculated. Less than 32 square centimeters in a man or 18 in a woman is consistent with sarcopenia. How does cancer cachexia develop, and why do some patients with cancer develop it while others don't? The answers are not entirely clear, but as of now, we understand cachexia to be the result of 3 main processes: system-wide inflammation, reductions in appetite and food consumption, and hypermetabolism and hypercatabolism, that is, tissue breakdown. Inflammation is a factor in many disease processes, from infection to autoimmune disease to dementia and aging itself, and cancer is no exception. The immune system responds to the presence of tumor by producing pro-inflammatory compounds like IL-6 and TNF-alpha, which can have strong effects on reducing appetite and promoting tissue breakdown. Some tumors even produce pro-inflammatory factors like IL-6 themselves. The ways in which inflammation promotes cachexia are still being explored, but overall, these changes create an environment that reduces appetite and promotes weight loss. In addition to the effects of inflammation on areas of the brain like the hypothalamus to reduce appetite, cancer patients have many other reasons for low appetite and low food intake. For example, pain and side effects of treatments such as nausea and vomiting and loss of sense of taste all contribute to a decrease in calorie intake. The calorie deficit in these patients is then made worse by a state of hypermetabolism, with many patients having increased energy usage even at rest. These changes in metabolism may be related to increased levels of mitochondrial uncoupling proteins, which generate heat rather than usable energy, or due to the process of aerobic glycolysis within the tumor, an inefficient use of sugar which then forces the liver to expend even more energy regenerating glucose for the rest of the body. Finally, patients with cachexia are often hypercatabolic, breaking down both fat and protein at an increased rate due to a combination of inflammatory factors from their own immune response and substances such as lipid mobilizing factor and proteolysis inducing factor produced by tumors. How is cachexia treated? It's not possible to cure, but one framework for understanding current and future management strategies breaks it down into three main areas: appetite, activity levels, and inflammation. In terms of appetite, patients with a diagnosis of or at risk for cancer cachexia should have early and frequent nutrition counseling and may benefit from oral nutrition supplements like protein shakes. There are many other treatments available that attempt to stimulate appetite and promote weight gain, like steroids, progestins such as migestrol, and cannabinoids like marinol, and we don't have time to discuss all of them in detail today. Briefly, steroids can improve appetite in the short term and help patients at the end of their lives feel better, but they can also promote muscle breakdown in the long term. Migestrol and similar medicines can cause weight gain, but this is mostly fat and water weight, not muscle, and they carry a serious risk of blood clots. Evidence for the effectiveness of marinol in cancer patients is limited. Other medications, such as low doses of insulin and anamirelin, a compound that mimics the hunger hormone ghrelin, are under investigation. Anamirelin in particular improved patient symptoms and lean body mass over a 6-month period in the Romana 1, 2, and 3 trials. For more information on nutrition in cancer, I recommend the 2008 and 2009 Aspen guidelines. For activity level, a randomized controlled trial of 60 minutes of exercise twice a week in patients with advanced cancer showed significant improvement in physical performance. Exercise might help patients stay stronger for longer and improve their overall quality of life, so it should be encouraged when patients are able. Finally, medications to reduce the inflammation in cancer cachexia, including indomethacin, N3 or omega-3 fatty acids, agents that target TNF-alpha and IL-6, and many more have shown mixed results so far and remain under investigation. Remember, when thinking about cancer cachexia, what's our goal? A successful treatment should improve the patient's duration and/or quality of life, not just produce weight gain. Here are our goals again. I hope by watching this video, you gained a better understanding of the important clinical syndrome, cancer cachexia. Thanks for watching.